Ramamurthy, the chairman of the Eye Foundation. He doesn't require any introduction. He's going to talk to us on monofocal patients getting closer to life. It's on IANS, no?
Yeah.
Yeah. Are you ready, Ramu?
Yeah.
Yeah, what, ma?
I'll speak and go after him.
Okay, Ramamurthy Sambandhi will go first.
I'm here.
Yeah, you're already there.
You can do this talk if you want.
Do one thing. Do it. Please share half of the screen. Half of the Maipal, half to Ramamurthy. It's called Sambandhi sharing. Sambandhi sharing technology. Ramamurthy, over to you.
So my topic, because I have to go for Maipal's course, I'm rushing. So get monofocal patients closer to life is the topic given to me. I think today the current standards of cataract outcomes has completely changed. What we expect is cataract surgery is no longer vision restorative but vision enhancing, and our patients are also coming to expect uncorrected visual acuity for all distances without any compromise in quality. They want immediate restoration of vision, and since we are operating on patients in their 40s and 50s and patients who live well into their 80s and 90s, what we do today should subsist them for a long time. So these are the various options that are available to us over the last three and a half decades that we have been doing intraocular lenses. But mind you, whenever you're using any kind of multifocal intraocular lens, which all of them work on the principle of splitting of light, there is bound to be some compromise as far as the quality of vision is concerned. You buy vision for all distances using the currency of contrast, and whether it's a trifocal, multifocal, EDOF lenses, invariably there is bound to be some amount of loss in contrast that goes with these lenses, and that is the reason you want something beyond multifocals. So depending on the type of slice that you're using, almost all the multifocal intraocular lenses come with certain amount of dysphotopsia, as you can see in this particular slide. And the simple reason is that multifocality was never in the scheme of things as far as nature is concerned. No mammal has a multifocal lens or a cornea, and when we do not mimic nature but do something non-physiological, it leads on to a compromise. And that is the reason we look for something on the monofocal platform. It is surprising that though almost 90% of the eyes that we implant are getting a monofocal intraocular lens, very little development has happened in this platform. Foldables came in way back in 1995, asphericity in 2001. Subsequently, it has been just some adjustment in haptic design, introduction of the yellow pigment, some square edge for PCO prevention, and better materials so that there's lens clarity and less incidence of glistenings, etc. But then the new technology that has been coming on in the Technis intraocular lens platform is something just disruptive, and that's what the IHANS is all about. This lens has been available to us. It was the first advanced technology lens that was introduced into the market, and still it's a very stable platform with its aspheric design, a Q value of minus 0.27, inherent ability to reduce chromatic aberration, a crystal clear optics, PCO prevention because of the square edge, and because of the material, the reduced chances of phimosis that is there. On this platform has come about the Technis IHANS lens, which is essentially absolutely indistinguishable when you look at it in the naked eye, or even under the microscope. You cannot make out any change between the normal Technis 1 lens and this lens. It is just a continuous change of power from the periphery to the center, and it is a unique anterior surface that improves the intermediate vision. So basically it's just a central 1 millimeter or 0.5 millimeters on either side, where there's a very little curvature change that is indistinguishable. And since there's a gradual progression of power from the center to the periphery, there are no diffractive rings, there are no zonal progression that takes place, because of which there's no dysphotopsia. As you can see, this is the center of the lens, and this is the magnified view of the center of the lens. The green line represents what is there in the IHANS, and the dotted line is what is there in the Technis. You can see it's almost indistinguishable even in bench studies, and that's the reason the dysphotopsia is not really a factor. And these are the earlier lenses that we had as far as getting some kind of near vision is concerned. The advancement in this particular lens is that there is no variation as far as the optics of the lens is concerned in the central area. And the good thing about this lens is that it has been shown that there is a intermediate vision, as far as it's concerned, there is a one-line improvement, whether it's been bilaterally implanted or unilaterally implanted. This is what is shown in the directions for use, that pamphlet that comes with the patient's each intraocular lens. Again, there is no drop as far as the distance vision is concerned. This is again something which is important. It's not just the quantity of distant vision, but even there is no difference as far as dysphotopsia is concerned. The profile of glare and halos is concerned. It functions exactly the same as Technis 1 lens. So what is the additional factor that it brings in, which is not offered with the Technis 1? Mind you, every monofocal lens also comes with certain amount of range of vision or depth of vision. What this lens brings onto the table as far as intermediate vision is concerned, it increases by one line the intermediate visual acuity, or it increases it by about 0.5 diopters as far as intermediate vision is concerned. So it's essentially redistribution of light that takes place. Mind you, irrespective of the intraocular lens that you have in your eye or the spectacles you are using, the amount of light that's going into your eye is going to be essentially the same. It is light which is taken out from this area from distance, which gets redistributed in this area, because of which the intermediate vision goes up by about one line. This is not just the studies based upon what Johnson & Johnson has done, but multiple other studies have also borne out this fact quite adequately. So the salient outcomes of eye hands over the monofocals is that there's an improvement in intermediate visual acuity by about a line. There's no deterioration in distant visual acuity, no increase in photic phenomena, and because of the larger landing zone that these lenses have, even if you have an error of about 0.25, 0.5 diopters, they are more tolerant to refractive outcome as far as distance is concerned. But you have these errors, then there is the whatever gain in intermediate vision is there is lost. So it's not a good idea to try micro monovision or monovision, but aim at absolute emmetropia in both eyes. I'll skip this video. It's exactly the same as Technis 1 lens, and I think we are short of time. So it goes in comfortably through a 2.2 or a 2.4 millimeter incision. And today, near vision is not that important. All these factors which we do in our day-to-day life, or a 60 or a 70-year-old is going to do, is intermediate vision dependent. And as far as this lens brings on something extra to the table, bilaterally implanted, this is a welcome addition to these lenses. So my primary indications, whenever a patient is seriously interested in multifocality, I do not recommend these lenses. Mind you, they do require 1.5, 1.25 diopters addition when it comes to near vision, good near vision. What a person who is extremely active, plays golf, travels around, but is very bothered about his distant visual acuity, quality of vision, but has less of reading requirements, is a primary indication. Is a patient who is interested in multifocal intraocular lenses, but when he has been counseled about the dysphotopsia which may come with those lenses, is getting put off. Again, we tell them that this is something intermediate between a monofocal and a multifocal. You can opt for this. Interested in multifocal but ineligible for the same, simply because the macula is subnormal, the ocular surface is not that good, or there is a certain amount of ocular aberrations, or it's a post-refractive surgery. Again, this might be a good choice of lens. I believe for in many of our practices, these lenses by and large replacing monofocal intraocular lenses. You do not talk about it to the patients, but then you just go ahead and put these lenses at maybe at a slightly higher cost, and these patients tend to benefit from it. I think J&J got it absolutely right in the sense that this was not promoted as a multifocal intraocular lens, but an improvement over a monofocal lens. That's the reason they did not have to go through a separate FDA approval for this. Neither do they claim that it's a presbyopia correcting lens. And most importantly, they priced it right in the sense that it's available just in a couple of thousand rupees more than a good monofocal intraocular lens, which I used to all the time. So we are able to offer it to almost every patient, allowing the benefits of some amount of gain in intermediate vision. Thank you so much for your kind attention.
Thank you, Dr. Ramamurthy, for an excellent presentation on this